now we'll move to our next talk, which will be by Dr. Don Frush. He's from Duke. He will be speaking on how to best use current technology for pediatric body CT. Thank you.
Thank you, Dr. Kalra, and I wanted to thank the meeting organizers here. This has been an extraordinary meeting to date. I mean, all the presenters so far have just been so comprehensive in what they've done. It's really been a who's who. And I also want to thank you all, because while we can get up and give you tools and give you information and so on, it's really you who will have the impact in what is done after this. It's not me or Manu or anybody else. So really thanks from the presenters to all of you. Just a couple other issues as I get started too. The topic of where you do the axial representation of the patient. I know in Boston it might be different for Dr. Strauss, but in North Carolina, most of our abdomens tend to be the widest dimension rather than the narrowest. And in line with that, one of the things that we have worked on at Duke is you'll hear more about the ACR dose index register. We provided the ACR with a way off of the topogram to automatically calculate a cross-sectional area, and what we defaulted to in that program was the widest dimension in that scan. And part of the reason for that was that if you're going to include the neck, or if you get down to the legs on the scan, if you did the narrowest dimension, that the percent change or difference was going to be greater than expected, much greater than expected. And if you took the wider dimension, and the widest might give you an overestimation, but it was that degree of difference was much less. So that was an answer there. All right. So I've been dealing with radiation. Lots of us have all our lives, and you've heard a little bit about biological effects, and Jim Brink talked about risk and so on, and I've had my share of exposures during angio and fluoroscopy and so on, and these are two of my children, and I just don't know why this risk of radiation seems overblown to me. But I'm not going to really talk about the risk as much as I'm going to really hopefully morph what you've heard earlier in terms of specifics of technology into what's more practical application for pediatric imaging. And the first thing I want to emphasize here, and we've heard a little bit about risk, we've heard about technologies to control dose and so on, and certainly one of the most pervasive issues with diagnostic imaging is radiation exposure, patient protection, and so on. Is we all have to remember that there is a huge benefit with CT, and that should be the overwhelming perspective by which we approach risk. And this is just an example of the benefits of CT. So it's a coronal reconstruction of a patient scanned axially, and the arrow here is on the diaphragm, this group of muscles that separates the thoracic content from the abdominal content, and as you can see, it's torn. And what happens when the diaphragm's torn is contents from the abdomen go up in the chest, which has happened here. Your liver does not reside in the right side of your thorax. So this was a kid just on a road late at night, not drinking, good kid, bad weather, went off the road, hit a tree, and came to our emergency room and was scanned, 15-year-old. This is life-saving technology, and if you have any question about the benefits of CT at all, these are the kinds of things that every radiologist in this room will say they encounter at least weekly about the life-saving. And if you just talk about change in management strategies every day, even if we say 50%, and Jim Brink talked about the overutilization, even if we said 50% of everything we do is inappropriate or has questionable utilization and so on, if you think about those risk estimates, then the benefits are far in excess of that. So I just want you to carry that with you throughout this meeting, and don't get diluted. Sometimes we do that with the articles that we put out and so on. The fact that CT is an evil modality, it's not really, is a wonderful way of doing great things. And the dad of this kid, whose name is Buck, I mean, what a great name for a guy from North Carolina, allowed me to use this picture, and this was a great friend of my daughter's. And so these kinds of things have direct personal impact and so on. So just remember, while CT does have dose, that it's an extremely useful modality here. I'm going to sort of go through I don't know how old all of you are, but this was I don't know what they do is there a Cliff Note tweet or something now that people use? But this saved many of us many times, late evenings in high school. But this is going to be the Cliff Notes for MDCT and current technologies in pediatric patients. Two great articles, just for reference. Keith Strauss was a lead author on one of these, and then another article that just came out the end of last year in the ICRP proceedings that really detail techniques that we can collectively use to control dose in pediatrics. And many of these things that I'll discuss are in these two articles. I think you're in your course syllabus, so you can refer to these at some point in time. We also have to consider that, and as you've heard, dose reduction is balanced by image quality. And while we continue to push the envelope lower, there is going to be a threshold at which we will be too low. And I think you've sort of sensed from some of the images up there that we're close to that. I would argue that we still have to get to that point, but we are much closer to it than we were 10 years ago. So, and there are times when you're going to need an examination, even in a child, that is a relatively high dose examination. So you can't simply subscribe to the fact that dose should be as low as you can get it. Dose should be as low as you can get it based on everything that you're considering, which includes the indication of the exam, prior scans, etc. So some of the dose management strategies as outlined here there are other modalities. You always want to consider ultrasound and MR, patient preparation, adjusting parameters, avoid multi-phase examinations, limiting coverage. These are sort of simplified dose approaches to children that if you subscribe to these can have a significant impact. And I'll go through some of the new technologies, but these are the fundamentals. If you do these, then you are addressing the vast majority of dose protection in children that you can have. Some of the lower dose pediatric MDCT that what we come across are large abnormalities, follow-up scans where you already know something's going on, say an abscess search or an empyema, is it bigger or smaller, high contrast regions, lung skeletal evaluation, and CT angiography. Patient preparation, and I have to say in 25 years I've been doing this, the ball has shifted to dose reduction in the last 10 years, and I think that's why you're all here. But I think we're going to have a patient preparation conference at some point soon, because the mistakes I see come in as outside examinations now often are errors in poor sedation and overranging in scans and poor contrast enhancement, poor technique, motion artifacts. Something should have been contrasted and wasn't. So these technical things, to me, have sort of taken a back seat to dose control. Because if you've got a kid who moves and it's a low-dose examination, that's a wasted dose. It doesn't matter how low that dose was. So these are things that I think have been sort of put on the back burner, and we need to readdress these in terms of scan quality. So here's a CTA that would have normally been quite good, and it was a fairly low-dose examination, but we neglected to, when we set up the patient, get rid of these cardiac leads here on the side of the patient. Significant streak artifact. Now, we were still able to see what we needed to see, but there would be some indications where we would have had to scan this child again. All right, so for those of you who don't do CT, this is actually a CT examination. It's not a nuclear medicine study. And this came in as an outside study, okay? And this was somebody who had barium. Barium and CT are not like peanut butter and chocolate, okay? They don't mix very well. And it's had barium study, got a CT examination, evaluate abdominal pain. This should have been picked up on the SCOUT, the topogram. It should never have been done, but it was done. So outside scan comes in. Now, it's not, and this is totally wasted radiation. So this is rule out appendicitis. This is a pelvis. for those of you who can't tell. Pelvic bones are down there. So it's sort of, a crime. You look at this, and it is funny, but it's kind of sad. The really sad part about this was the report. It said, limited examination, but no evidence of appendicitis. Well, there's no evidence of, like, a pelvis, too. I mean, good heavens, what? And so, again, these patient preparation issues, this might have been a very low-dose examination, but it was totally wasted because people don't pay attention to patient preparation. Another example, child had a chest x-ray, left lower lobe mass. One of the things in kids we think about as a congenital abnormality called a sequestration. It's curable, they take it out. It's just a congenital thing that has some abnormal blood vessels that come from the aorta and go away from this mass, and it's a reasonable thing. But I would argue that this scan had the same report as the chest x-ray, which said left lower lobe opacity. We were not able to identify blood vessels. We weren't able to provide any better information because of poor sedation and poor contrast administration. So we're right at the junction of the abdomen and the chest here. So we had to do it again the next day. It's the same kid, same area, better contrast administration, and sedation. You can see down in the right lower image there, I know I'm going to mess up this arrow, so I'm just going to point to it. Right lower image there. See that big vessel coming off of the aorta by the spine? There we go. That is a sequestration and a draining vein there. So, properly performed, well-prepared patient, still a low-dose examination is the key here. I'm going to talk just a little bit about some of these major things that we can modify before I get into special technologies. Tube current and kilovoltage, as you've heard, are two fundamental things. They're like cameras. For those of you who know, we used to have to adjust cameras like with f-stop and shutter speed. Does that sound familiar to some people? And it was kind of nice, but so much easier now. But this is sort of our shutter speed and f-stop now. These are the things that we can adjust quite easily, and I'll get to those other technologies. But let's just look at these. So here's an example of what a decrease in tube current will do. So this is a teenager with appendicitis. The arrows show where the appendix is down here. All of our scans that do come with arrows after we scan it. It's quite nice. I wish. And here is a scan with one quarter dose reduction, 3/4 of the dose. And this is a program we've been working on for about 10 years where we just add noise to the scan data and we make it look as if it was done at a lower dose. And it's quite a nice paradigm because we don't have to scan patients multiple times. And, whoops, I'm going to try to go back here. And you can see the appendix is quite nice here, 25% reduction. I feel most radiologists would feel comfortable with that. Now, if we add a bunch of noise, so that it's 1/4 of that, this is difficult to see. And I think most people would say, I'm not really comfortable with that. So just an idea of what the tube current reduction can be and some of the science that we've been involved with in terms of determining thresholds with this. So here's an example of a low-dose chest CT looking at a pectus abnormality, which is, as you can see, a sternal abnormality. It was funny. I was watching TV once with my kids, and there was this Disney show, and they had sort of like fun tricks that kids could do. And they had these two kids on there. They were brothers, and their trick was that one kid would pour Cheerios into the other kid's chest and pour milk and eat it out of it. And he had a huge pectus abnormality. Now, they didn't know. I'm sure the Disney studios didn't know that, but I thought, when this kid's 15 years old, I don't think anyone's going to be eating Cheerios out of his chest. He's really going to be quite upset about this. But this is what a pectus abnormality is. And it can restrict lung function and cardiovascular function. And what we need to do is to sort of determine what the dimensions are. What the dimensions are here, AP versus medial lateral. But you can see this is a very low dose, very, very noisy examination where 40 MAS was used. And this is probably in the order of dozens of chest x-rays rather than hundreds or so. Another examination, this goes back to the simulation technology I talked about where we add noise. This was a child with a kidney stone, and you can see it's a fairly high contrast abnormality we're looking at here, but as we add noise and as we get to 1/6 of the original dose here, we can still see the stone quite well. So kidney stones are something else that are amenable to a lower dose examination in children. So as you're seeing, there are certain applications for which dose modification can be made in pediatrics as well as adults. So let's look at KVP a minute, and you've had some elegant introductions to what KVP does here. I will just summarize that because we have small cross-sectional areas, and oftentimes, especially with CT angiographic evaluation, we have high contrast things we're looking at, we can use a lower KVP. So it decreases the radiation dose. The contrast will increase, the noise increases, but the contrast to noise increase, depending on the indication, the size of the patient, is more favorable. And so we tend to use lower KVPs in children, rarely going up to 100, almost never 140. And really 80 and 100 is sort of the target for what we do. And it ends up being a win-win because we get good diagnostic quality at a lower dose. So I'm just going to show you a little bit because sometimes pictures are easier than, deltas and gradients and so on. So here are some phantoms in a CT scanner at 120 kV and 100 MAS. When we go to 10 MAS, look at the noise increases there, right? Let me go backwards. If I get the backwards one here, right? No. Okay, back, 120. So watch, the noise will increase here. Okay? Contrast stays the same. We just changed the tube current. Now, let's go back, and what we're going to do is change the KV down to 80. See what happens there? Back. See, our contrast increases and our noise increases, but with smaller cross-sectional areas and high contrast examination, that ends up being favorable. And if we go up to 135, nice smooth images, very little noise, but our contrast goes down here. So think of these cylinders as little tiny children. Here's an example of chest CT. Right side of the heart is opacified. We're looking at the pulmonary arteries. Nice pulmonary arteriogram here. Very low MA, very low KVP. Again, this is in the order of dozens of chest x-rays rather than hundreds in terms of what we're able to see by taking advantage of lowering the KVP in children. Now let me move on to one of those other major modifications that we do, which is to avoid multi-phase examination. So when you do a pre-contrast or post-contrast study, or you get delayed images, then it's an additional phase. And unless you change the settings, the dose is going to be a multiple of how many phases you do. And oftentimes it's necessary, but not always. And it tends to be done more in adult imaging than it does and should be in children. I've seen up to 5 phases done in pediatric scanning. I don't know if they brought the kid back on his birthday and scanned him again or what, but it was crazy. There's almost nothing that you get outside of 2, at most 3 phases. Now, there are some situations when you need to do it, and here's an example. Sometimes with renal imaging, we will do this. This was a child that has a cyst on the lower part of the left kidney right here. And we saw that with ultrasound and was going to the operating room because it could have been a tumor. The surgeon, the urologist, wanted more information on the extent and nature of this. So we needed to get pre-contrast studies because we wanted to measure any change in the Hounsfield units to see if that cyst enhanced, which it didn't. We wanted to be sure that that wasn't part of the collecting system, and it wasn't because contrast on delayed images didn't go in here. But you can see this is a very noisy exam, but all we needed to see was whether contrast went in here. So when you do multi-phase examinations, it should be the exception, and it should be directed at what you need to determine here. In this case, this was about 1.3 or 1.5 times the dose that this single phase was right in here, just by doing these 2 other scans at a lower dose here. And as you can see with coronal reconstructions, we see this very nicely and got good information. And this ended up being a congenital abnormality of the kidney. The child did not need to go to the operating room. These things resolve over time, and we actually saved him an operative procedure. But it was a fairly low-dose examination, even when we use multi-phase exams. And in pediatrics, probably 3 or 4% of all the scans we do are multi-phase. It tends to be higher in adults. Now, going back to dose reduction and contrast administration, I want to emphasize again that it's not always dose reduction. The administration of contrast, the type of contrast you use, etc., are important factors. You can lower the dose, but if your timing is bad, you're going to miss something like this, a very small endocrine tumor in the pancreas. This is normally when we acquire our scans, but because this was the indication, because we scanned earlier, seeing the contrast in the cortex of the kidney versus in the parenchyma here, we detect these lesions. We knew what we needed to do. So, again, it's paying attention to all the issues with CT, which are going to add to your patient, to the quality of scans, and optimize your dose protocols. So let me go through in the next 15 minutes or so some of those things you've heard about and will hear about, but again, more of an application standpoint here. And I'm not going to spend much time on tube current modulation. You heard a lot about it. Manu has written a great deal. A number of the physicists in this room have really provided some excellent educational materials here. This is one of the most significant things we've done in the last decade in terms of dose management, both in adults and children. But I do want to emphasize one point, and that we discovered very early on as this came out that children are different than adults. I mean, you've heard that before, it's not just a small adult. And the other side of that is a lot of adults act like children, which is probably true. But from a scanning standpoint, we do need to treat children a little differently. And our observation was the following. So here's an abdomen CT scan. This is pancreatitis. And you can see the pancreas here and all this inflammation. So I don't do adult imaging, but I think my colleagues would agree. It's a pretty good example of pancreatitis, and it's a reasonable image quality here. And taking regions of interest, several areas, we sort of got a mean Hounsfield unit of 21 or 22. Okay, and that's probably a target for some noise indices, say, on the GE scanner. But when you look at children, and this is the same patient scanned 2 different times, immunocompromised, possible infections in the liver, microabscesses, something that we probably need to use a little higher dose to do, and 2 different times we scanned, one at a noisier technique, less radiation, and one at a greater radiation dose. And you can see this lesion quite well in both, but boy, this one is sort of lost. I mean, it's kind of right there, but this is something that's going to be more challenging to see. But if you notice these numbers over here, 5.9 and 12.8, those are way different than the adult Hounsfield units. So what we discovered is that we need less noisy images in very small children than adults. And there are a variety of reasons for that. But because of that, when we've designed our protocols, and I'll put my email address at the end of this if anyone wants protocols, you notice that our age-related protocols here, beginning the youngest children with pink down to black, which is adult size, that we have different noise indices, and we have different noise indices for the chest and the abdomen. Now, these are modified a little bit as we've invoked ACER and some other iterative reconstructions. But the point is, you can't just apply the adult noise the adult programs that are supplied by manufacturers to children because you're going to get very noisy-looking images. And it's going to take work with application specialists and medical physicists and so on to perfect those things. Adaptive collimation, sort of a complex thing here, but basically what that does, and most of the manufacturers have this now, is we used to just sort of throw away radiation at the beginning and the end of the scan, but now we have a way with shutters to have these shutters close and they open as they go through the patient. So now we've controlled and eliminated some of this radiation down here and through the region of scanning. So can result in dose savings of up to 10%. So that's a relatively new technology. KVP selection, you've heard a great deal about. These are some slides from Siemens just illustrating what I showed you earlier about tube current reductions and the effect on fat, the effect on contrast, and so on. And they are based on the Siemens tube current selection is based on size and anatomy that's taken off the localizer here. And then you've got a toggle that you can use to determine what kind of scan quality you're looking for and what noise you'll tolerate here, sort of a contrast-enhanced liver, musculoskeletal work, non-contrast study versus CT angiography. And so what you do is you put in what you think you want, and the machine will say, well, actually, you can get this equal noise or this equal image quality by letting us tweak your KVP a little bit, and we'll push your MAS up a little bit. And it's a tool that has had some benefit, I think, from applications, and certainly in the adult literature, as you can see here, what you put in with the original scan gave you a CTDI of 15.3. By applying the CARE KV or the tube current or the KV selection, you could reduce your dose by a percentage there. And the image quality, actually, you see a little bit more contrast enhancement because of the lower KV. I've tried this a little in kids and have not had much success. In the smallest kids, it's a little more challenging. So I would caution that you know how to use this well before you start applying to children. I think in concept it's good, but we scan a lot of very young children, and I just have not found it entirely successful to date. organ-based modulation that you may hear more about, and this is a unique way of reducing the doses. The scanner goes around, it has a higher dose through the sides and the back, and then once you get to the front, turns it down. It doesn't go to zero. I think it drops it by about 40% or so, and then it increases it through here. And the idea is through the thyroid or perhaps through the lens of the eye or certainly through the breast tissue that you have what's called an organ-based dose modulation. And it makes some sense to do that. And we've actually tested this. This is radiochromic film. So this is placed in an axial slice of a phantom, and I think it illustrates nicely when this technology is off, the dose distribution, sort of in the center, fairly homogeneous, versus on. And see, darker red is a bigger dose here, and lighter yellow is less of a dose. Through this 120-degree arc, this is the anterior part of the phantom, how it turns down. So it represents, actually, when we tested it, it did what it's supposed to do. But one thing you'll notice is that, look at back here. This is now pretty red back here. So what you gain by turning it off anteriorly, to some degree, is made up scanning posteriorly. So you may reduce the breast dose, but the bone marrow dose, the esophageal dose, the posterior dose is going to go up because we're maintaining photon flux here. So understand that it is a technology that has some benefit from that, but it does have some potential costs too. Here are some cutouts of lungs we did that show with this technology on what it did to pediatric 5-year-old phantom versus with the technology off and the decrease in anterior dose. One other thing to keep in mind is, and gets back to what the North Carolina body morphology is, it's always nice. 120 degrees does not incorporate all the breast tissue. And this was an article that came out a few months ago that a colleague at Duke did. And you can see the phantom dose here with the organ-based 120 degrees on, and that's nice because these are phantom breasts within that, but these are actual breast tissue. And in order to get all the breast tissue, you almost have to have 180 degrees. And remember what I said, too, about this organ-based dose modulation starts to increase once you get out of that arc. You're actually doing more radiation exposure to these areas than you would be if you didn't use it at all. So it's just a cautionary note. Understand the technology. This is not something that we've applied in pediatric imaging, and I think Diana Cody's done some nice work with scanner modifications that you may talk about later with ways to reduce anterior surface dose as well. In-plane shields. This is simply the breast shields, the bismuth-coated breast shields, and so on. And I know the AAPM has come out with a strong statement advocating for tube current reduction, and that's a great way to do it. That's correct. But I just want to emphasize that it's not the only way to do it, and using these breast shields, if they're appropriately placed with a standoff and done correctly, it's not a bad way to do it. There are a number of articles out that are pros and cons with this, and all I want to say is whether you use them or not, you just need to use them correctly. It is a much simpler thing to do, and not everyone has a Diana Cody or a Cynthia McCullough or a Michael McGray to do their protocols, and it's a whole lot cheaper and simpler to do that. So there are some benefits and some advantages. And the final thing that isn't really emphasized is what does a patient understand? You put shields over her breast. Well, why are you doing this? Because we can reduce the dose of your scan somewhat. Okay, they understand that. Versus, well, what do you do to reduce the dose of my scans? Well, I have Diana Cody come through and she looks at our protocols and she turns down the tube current so it maintains a more consistent photon flux through your body, but we found that it doesn't change the attenuation. A woman's going to go, okay, I'm sorry, I asked. So from a standpoint of a patient understanding what you're doing, using these shields does have a greater impact. But again, and I'm not arguing for or against. I just want to say that the breast shields are not a bad way to do it. They're a different way to do it. There is some effect on attenuation, but most of chest imaging unlike body imaging, doesn't use attenuation differences for diagnosis. Most all of that doesn't. Dual source CT. This is the Siemens CT and just an illustration of a single source here with a temporal resolution of down to 165 milliseconds versus when you have two sources here, you can get much better temporal resolution. And for children, this is really wonderful because it really freezes respiratory motion. For ILD studies and so on, we used to have to intubate these kids, and we used to have to do a respiratory pause, and it was quite complicated. But on this scanner, the dual source Siemens scanner, we don't need to do that anymore because you can get high-res cuts in a breathing infant, even if they're breathing 30 or 40 times a minute. So it really is some nice technology here. And here's an example from the gated cardiac standpoint of what I'm talking about. So single source CT and dual source CT, you can see on the dual source CT with that range of scanning, the amount of time to acquire that image through the heart is coming upon parts of the cardiac cycle which are not optimal in terms of evaluation. But when you use a dual source CT, that acquisition time is so much smaller. So even with heartbeats up to 120, 130, 140, at least with retrospective gating, we can go back and get great images without having to do any beta blocking. And if you beta block a 1-year-old to a heart rate of 60, that scan's going to be over pretty quick because that emergency department's going to be in there. Kids don't tolerate heart rates of 160 to be able to do this. So it's another advantage in terms of respiratory motion, other motion suppression, so dual source CT. An example of a sort of curvilinear reformats. This kid had Kawasaki's disease. It's a vasculitis that affects coronary arteries and other medium arteries. And I'll just show you the right coronary artery here. Was really thready. This is what it should look like all the way through, and see how it gets a little thready here. And there were some areas of stenosis and irregularity here that were seen on the catheterization as well. But now we're able to follow this child using a gated cardiac study rather than using catheterization, which has its own risks here. And this is a fairly low-dose study done on a dual source CT without the need to beta block. Here's some other examples. Again, this was a child that had a dual source scan, post-op anomalous venous repair, and that's when the veins don't drain when they're supposed to, so the surgeons just hook them up to the right chamber. So the right chamber is the left atrium right here, CT angiography, and here's where they come in. But you can see a stenosis right there, the confluence of the pulmonary veins, and a stenosis right there. This is not a gated cardiac study. For those of you who have looked at CTs, this anatomy ends up being quite good. And so for large vessel abnormalities, for origins of coronary arteries, for pulmonary veins, pericardiac abnormalities, we don't need to gate studies anymore. This is simply an acquired study with a non-gated technology, which decreases the dose. Another example, this is a child that had suspected sequestration. There was a mass up here. We did an ultrasound. The thing with ultrasound is you can make anything look like you want it to look, and so the suggestion was, there's an artery coming off somewhere, and we believe this is a sequestration. A little bit of an unusual location because most are at the lung bases. So we did a CT angiogram, high-pitch mode with the dual source scanner, and we used bolus tracking, which I would advocate on all young children to do. And you can see once we get the aorta just a little bit opacified here, then we start scanning. We get really nice aortic information. And these are all 10 MAS scans. So it's a very nominal dose to get these images done. And here's this actual study, and there wasn't a sequestration, so this is normal. Don't deal with whether there's an abnormality or not. But what I want to point out is, again, this is non-gated study. That is the aorta. Look, you can see the cusps of the aortic valve. You can see where the pulmonary veins come in. Origin of the coronary arteries here. Here, see that? Really nicely depicted. Very low dose exam. We don't need a low pitch because it's not a gated cardiac study. So some new technology, the dual source, has really been a boon to pediatric imaging in terms of motion control and getting high quality images. And a little better magnification here. You can see the papillary muscles and moderator band, and the lung images look quite good as well. Volume CT, as we get the wider detector arrays, this is the Toshiba scanner, a colleague from Children's Hospital, demonstrates what the wide detector arrays can do in terms of volume acquisition. Now, all of our imaging is small parts, so this is great in adults for cardiac work and for looking at circle of Willis, because you can get this information in a certain single rotation and don't have to worry about misregistration and contrast enhancement and so on. And so this volume acquisition is quite good. Well, a volume acquisition might be a whole abdomen or a whole chest in a child, and with a 0.3 second rotation time, it's not a chest x-ray, but it's pretty doggone quick here. And so this is new technology which has certainly great applications for pediatric body imaging as well. Iterative reconstruction, you've heard a lot about this. Just some examples. We use both Sapphire and Acer here, and Sapphire 3 is what we've defaulted to. You can see the 5 here is a little bit more plasticky here, and we just found that 3 is good for most all of our body work. An example of thin slices with Acer, with Sapphire applied right here, and then with a 5 millimeter thick slice, 1/3 of the routine dose. We're really operating between about 40 and 60%, so I think the estimations I heard about 50% reduction with much of this technology is a great target. And we also have Acer here. Not as great a reduction because it's not as full of a reconstruction as you saw with the Sapphire, but going from the original to a 40 here, you can see some noise reduction. And I will say this is a very low CTDI vol for what this chest CT was here. It is a 32 centimeter phantom estimation, but even if you multiply that by 2, it's still very, very, very low. This is ADER, the Toshiba product, and application of 3D by Dan Podboreski, again, just showing the increased image quality you can get. And again, I'm not going to deal much with the technology, but this does have application and direct application in pediatric imaging. And I think with applications of these technologies, that dose reduction of certainly 1/3 to 50% is very easily achieved. And just some work from Dr. Podboreski where they're comparing the SSDE to some smoothing algorithms to the ADER, and you can see based on the cross-sectional area and so on the dose savings that they've had. Here are some of our protocols. It's very complicated. Siemens on the left, GE on the right. We built in our Acer, we built in our noise indices, and so on. Again, anyone wants these protocols, I'll be happy to give them to you. Some of the things that we need to do in terms of further advances beyond the technologies I've talked about, cultivate research. I just wanted to go through and show you an investigation of appendicitis using this simulation technology from RSNA, and here's an evaluation sheet. Is by adding the noise to the image, is it present, is it absent, how confident are you? We're going back to those studies I showed you with the teenage boy where we added noise. This is systematically how we've done this in about 5 or 6 different paradigms. So normal appendix. This is the usual body habitus that we're seeing in North Carolina these days. A lot of extra abdominal soft tissue here. See the appendix quite nice. If we do a 50% reduction, still see it. 75% reduction, I think most people would say. It's getting a little dicey here, but I can still see that. Now we look at this, where the appendix is abnormal in the midst of other bowel here. The original scan, 50%, yeah, probably, but boy, you get down to 75% reduction, and that's not really good. So when we compared these different scans, and again, this is just adding noise. We didn't have to scan these children again. You can see that there was a significant difference in the 75% reduction versus the 50% in the original scan, and that is both for the normal appendix. That's for the normal appendix here, but for appendicitis detected, there wasn't a lot of difference. But if you look at reader confidence, you can see people are less comfortable with that. So, you saw the noisy images, and it's harder to work around these things and to detect these abnormalities. But the fact of the matter is, whether you're comfortable or not, you can do a good job. So part of what we need to be able to do is to relearn to look at iterative reconstruction, to relearn to look at noisier images, and to be able to make these things, because we actually can do that. Provide practice guidelines, educate, align with organizations, align with industry, and develop safety and quality paradigms here. And quality improvement, the dose index registry you'll hear about. These are centers that have it, and then those that have it and have activated it. This is what we've done at Duke. We have our own dose index registry where every CT scan goes into a separate server, and through optical character recognition, we look at the DLP and the CTDI vol, and we can display information such as this. And a number of institutions are doing this. A number of commercial products are available. This is a mandate that we're going to have to do. So it's something that we have worked hard to do in our pediatric and adult populations, as part of a quality program, you want to identify the outliers, those that are too low and those that are too high. Establish what those ranges are, and part of the dose index registry is going to allow us to have reference ranges here. They simply haven't existed for years. So, in conclusion, here's my email address. If you want protocols, if you want to talk, please get in touch with me. I want to thank you for your attention. Again, you are the ones who are going to go out and make this work and not work. And I'd be happy to take any questions, and I think we have a few minutes. Thank you very much. So maybe I should have used the audience response system because people seem unresponsive here. Isn't that the point of?
Okay, I have a question.
All right.
One of the things we've started doing for pediatric exams where we want delayed images is to not cover the entire organ, not cover the entire kidneys and bladder, but just take one axial cut at each location. An axial instead of helical, because helical includes that overranging part. Have you adapted stuff like that? Have you heard of other people doing that kind of thing?
We don't, but that makes perfect sense. And if you just need some limited information, like through a ureter or a kidney, is the bladder leaking, those are perfectly reasonable things to do. Again, it's a nice technique to tailor that individual scan to what you need on those delayed images, because you're right, we often don't need to see stem to stern on those. So in addition to turning down the technique to acquire less tissue, irradiate less tissue along the way is certainly reasonable.
The other thing that we've been toying with but haven't really jumped on yet is the idea of doing, for a chest, abdomen, pelvis, which we don't do as often in kids as we do in adults, one pass, as opposed to the chest having some overlap for each region. How do you do that? Do you do it all in one pass? Because IV contrast isn't perfect anywhere if you compromise it. Is that not true?
So there are two separate issues. One is the technique and the image quality related to the radiation dose, and the other is contrast. With the faster scanners, at least with a dual source, you can get a CTA from, the circle of Willis down through the pelvis, no problem. Even if you acquire one, in one time slot and shift around, it is just so fast. So the contrast issue isn't really a significant issue. I believe that the chest needs a lower KV and needs a lower MA. And if you've got an appropriate KV selection and tube current modulation set up to be able to do that, then it's helpful. But I don't think all manufacturers allow you to do that with a single noise index and so on. And they may have changed, but there are some nuances that you can't use the same thing. And like I said, too, through the chest, we use a different noise index than we do through the abdomen. And we can't really go through in one fell swoop. We do have to stop and then rescan. That amount of overlap is an issue, and there is some overranging involved with that, but we have not gone to a single acquisition from all the way through the chest. We still do the chest, then the abdomen and pelvis as two separate acquisitions.
Obviously, the research in terms of what radiologists can be comfortable with in terms of noise level is really critical if we're going to progress forward. The challenge whenever I talk to radiologists is, but I got patients in front of me and I'm not really sure what the incidentals might be and where is my comfort level with the noise. One of the big benefits of what you showed, and a couple other investigators have done it, is adding noise afterwards. Is there any plan to make that kind of capability more broadly available to the community of radiologists so that a radiologist could do their own sort of gut check to say, okay, well, here's an image, let's log on to this system or let's buy this software and let's add noise to my own images so that I can gradually increase my comfort level with noisier images. Right now, to my knowledge, that's limited to the biggest top universities.
Well, that's a great question, and I think Manu is arranging a refresher course at RSNA next year that is going to look at these issues, and it will be sort of user-selected opportunities to control image quality by changing the various factors. So it's an advertisement for his refresher course. Now, there is no commercial package. So if you and anyone else in this room wants to write the NIH and tell them that this is really important, it might help a number of us in the room that are currently submitting information to them to develop this very product, because it would be nice to be able to say, this is kind of what noise is going to do. It's going to affect small liver lesions this way or lung parenchyma this way. But there's no product out, as best I know, that does that. It's all proprietary and provincial at this point in time.
Thanks.